بسم الله الرحمن الرحيم. We have a diagnostic approach or diagnostic dilemma to the intracavitary uterine masses. I think we have put many cases on the group with different pathologies of the intracavitary uterine masses. How can we approach? First, as we always do in the gynecological or female imaging, all female imaging, we should categorize patients into childbearing age or in the post or perimenopausal age group. Because in the childbearing age we have different causes. The most common is polyp, which cause dysfunctional uterine bleeding, submucous fibroid, focal hyperplasia, and pregnancy-related condition. This should be put in this age group. Like incomplete abortion, and we have seen a lot of cases of retained products of conception, gestational trophoblastic disease, and ectopic pregnancy. And sometimes the ectopic pregnancy is cornual or interstitial, so it may appear as polypoid lesion inside the uterus. And then came the very rare in this age group is the endometrial carcinoma, but still it's present. In the postmenopausal or the perimenopausal age group, we have endometrial cancer. The first, it's not the most common, but it is the most dangerous. So we have endometrial cancer, endometrial polyps, and submucous fibroid. Here a case of retained products of conception. This patient was coming after abortion with this mass protruding inside the cavity. We see here in the 4D image there is an echogenic mass present, and mainly it is a cornual interstitial pregnancy likely, and this is the mass still present after abortion. So this is a case of retained products of conception. Regarding endometrial polyps, which is the most common especially in the childbearing age group, what is an endometrial polyp? The endometrial polyp or uterine polyp is a polyp or lesion in the endometrium that take up space within the uterine cavity. So we put it as a differential diagnosis of intracavitary masses. It is commonly occurring in 10% of women may experience the presence of polyp at any time of their life. They may have a large flat base. This polyp may be sessile or may be pedunculated, and the pedunculated polyp, if large enough, can prolapse even through the cervix or vagina. So it may be sessile or pedunculated. Pedunculated polyps are more common than sessile ones. They change in size from few millimeters to several centimeters. If pedunculated, they can protrude through the cervix into the vagina, and may protrude also into the vagina. The polyps may have small blood vessels, but the main clue to diagnosis is the presence of single feeding vessel, which we call it on Doppler the vascular pedicle sign. In the transvaginal ultrasound, we can detect polyp even without doing sonohysterography. It causes focal bulge in the endometrium. Here is the endometrium. It is in the proliferative phase, triple line sign, but here in the left side there is a focal bulge within this endometrium. So this is a focal bulge. And also if you see, there will be cystic changes inside, and this is more with the endometrial polyp. Usually the endometrial polyp on ultrasound is hyperechoic because it is arising from the endometrium. And here we confirm by Doppler that we have vascular pedicle sign present. So this is the appearance of polyp. Something I will tell you from my experience: if you find thickened endometrium and you couldn't delineate if there is polyp or not, please tell the patient to come just after her menses. If you find this focal lesion is present, then it is polyp. So this is instead of doing other investigations, just it is serial sonography positive. If it is positive on serial sonography, then it is polyp. Here is this another polyp. Here this is a focal hyperechoic lesion present, and the endometrium is seen splayed over it. Here there is no the typical vascular pedicle sign, but there is fine vessels present here inside this polyp. And this is another polyp. This polyp is large. It is a large polyp with vascular pedicle sign also seen on power Doppler. So this is a vascular pedicle sign. So what about this one? Is this the same? No, it is not the same. It is hypoechoic, or we can say that it is isoechoic to the myometrium. It has a myometrial base. We have here a myometrial base, and the endometrium is seen splayed over it. So this is an intracavitary fibroid or pedunculated submucous fibroid, FIGO stage 0. If you have a look down to this, we have another lesion here showing cystic changes, and this is a polyp. This is a polyp here. It's not so hyperechoic, but there is cystic changes present inside, and there is no myometrial base inside. Here also, this is an isoechoic mass lesion, small, but it has perifibroid plexus and not vascular pedicle sign, and so this is an intracavitary fibroid. So in many times, if the lesion is small and we could delineate the surroundings, we can differentiate between polyp and fibroid on ultrasound basis. But in complicated cases, we have to do MR then. Here, 3D ultrasound is also very important in delineating the lesion and delineating the size of the polyp. Here there is a polyp in the right corner of the uterus, and this is the endometrium is seen on the other side of the polyp. So this is also a right cornual endometrial polyp on 4D image. But what about leiomyomas? Leiomyomas typically develop in the uterine corpus or fundus and may also originate on the cervix. And sometimes it is called parasitic leiomyoma. It may be parasitic on the surroundings. But what about the intracavitary leiomyoma? This is what we are talking about today. This is the intracavitary leiomyoma. Here, this one, this is the FIGO stage 0, the intracavitary leiomyoma. And it has pedicle, and usually, as we say, isoechoic to the myometrium in most cases, except if there is areas of degeneration and there is perifibroid plexus within. This is the fibroid we've seen before. See here the vessels around the fibroid, and there is no vascular pedicle coming like the polyp lesion. This is another case. It's also isoechoic to the myometrium. There is myometrial base, and this is the myometrial base, and the endometrium is seen splayed over. So this is a intracavitary fibroid or submucous fibroid. This is another one. Here, this is a fibroid. But here I will tell you that the 4D ultrasound is better than the 2D. Sometimes in the 2D you could not delineate whether it is just compressing the endometrium on the edges and it is submucous or intracavitary, and by 4D ultrasound here we can see that it has a myometrial base, and this is the intracavitary fibroid. So the 4D gives better information than the 2D image. And this is the typical perifibroid plexus of vessels. This is the typical perifibroid plexus of vessels, not like the vascular pedicle sign of the fibroid. This is also another fibroid. It is distending the cavity, and the fibroid is again isoechoic, and it has myometrial base. This is another case, also an intracavitary fibroid prolapsing through the cervix. Note here it has whorly appearance. It has whorly-like appearance, and this is also consistent with fibroid. But being very large, sometimes the signal, the echo pattern is different. But here it is arising from the anterior myometrium, like the Broccoli sign, we will see it after that. And it is coming from the anterior myometrium and then prolapsing through the cervix. So this is again an intracavitary fibroid. And here is the vessels. So someone will say, so this is a vascular pedicle sign, but it is in the in the myometrial base of the fibroid. But when you see here, you'll find that there is vessels surrounding the fibroid lesion. So when it is prolapsing fibroid, sometimes we'll find a vessel coming from the myometrium feeding it like the polyp. So this is the ultrasound. What about the MRI in the intracavitary masses? Regarding MRI, we will take some cases at first. This case, she has multiple fibroids. There is multiple hypo-intense fibroids all through. But what about the endometrial cavity? And many fibroids. There is some interstitial and some subserous. This is one subserous, but they are all small. But regarding the cavity, there is here an intracavitary mass present inside the cavity. Here there is an intracavitary mass. It has not the same signal intensity as the rest of fibroids. This is the lesion. Note here, this is not endometrium. This is not the signal of the endometrium, and the endometrium is seen splaying in the periphery. Again, multiple sequences. You will find this, the endometrium, and then there is other lesions present inside. And this is the coronal showing an iso-intense lesion present inside the uterus. On post-contrast, it does not take contrast or very faint contrast like the other fibroids. So what to say? It is not the typical signal intensity of a fibroid. Maybe fibroid with hyaline degeneration, for example. But we cannot differentiate it purely from polyp. This patient may have polyp and fibroid at the same time, but you can say at the end that it is just an intracavitary lesion. Here there is faint enhancement only. So we can say in the end that we have fibroid uterus and with an intracavitary mass. I could not differentiate from the MRI here if it is fibroid or polyp associated with this accidentally discovered with the fibroid uterus. But here, this pedunculated prolapsed mass coming out from the cervix to reach the upper vagina, it has a pedicle coming from the anterior myometrium. It has a pedicle coming from the anterior myometrium, and then here note the signal intensity. It is hypo or iso-intense to the myometrium. It is hypo-intense 52. Hypo-intense 52 with fibrous tumors, so this is a fibroid. This is a fibroid. Also, the patient has accidentally, she has also adenomyosis, and usually the adenomyosis and endometriosis usually associated with fibroid lesions, and she has cyst in the ovary also here. But this is the signal intensity of a prolapsed fibroid. It takes the same enhancement as the myometrium, so this is a pedunculated prolapsed fibroid. This is another case. This is a female patient. She's not young, and she's in the postmenopausal age group or perimenopausal age group. And then here, what we can see, again, this is the uterus. This is the uterus. The uterus is retroverted. Note the fundus is looking posteriorly. And there is an intracavitary lesion present inside, hypointense. This is not the normal endometrium. This is not the normal endometrium. The junctional zone, sometimes in the postmenopausal age group, we could not delineate the junctional zone well, except on diffusion weighted images maybe, or on contrast enhanced study. Note here the contrast enhanced study. Here this is the Thrive. And here is the starting to take, usually you can take dynamic. In endometrial lesions, you must take contrast dynamic. Here the lesion is not taking contrast enhancement at all. In the early stage, there is no contrast enhancement. Starting in the delayed, this is in the early, there is no contrast enhancement in the early stage. I will see you a picture in the delayed image afterward. Here is the lesion. So it is hypo intense on T2. The junctional zone could not be accurately delineated on these images. I think there was one picture, there was mild irregularity of the endometrium in one part. I miss it here, but there was mild irregularity in one part, and so this was with endometrial lesion, cancer, with the age of the patient also. So this was an endometrial cancer stage 1. On MRI, what is the appearance of endometrial polyps on MRI? On MRI, the endometrial polyp are usually of intermediate signal intensity on T1 with heterogeneous high signal in T2, and sometimes we could see cystic changes. You know, this is a polyp, so it is high signal on T2, not low signal as the carcinoma, and that we can differentiate from endometrial carcinoma based on the morphological features, even if it is a small cancer. A central fiber score of low signal on T2 and intralesional cysts, smooth, well-delineated structure, all this is with endometrial polyp rather than endometrial carcinoma. Here, usually intermediate signal intensity on T1 with heterogeneous high signal in T2. And this is there is fiber score sometimes seen in the images, especially on the sagittal view. And this is an endometrial polyp on MRI. Here is the endometrial polyp, and it takes heterogeneous enhancement on post-contrast. It takes enhancement, early enhancement. Usually we have use that early enhancement usually with malignancy, but regarding endometrial polyps, if it takes delayed enhancement, it is more with cancer than it takes early enhancement more with endometrial polyps. Endometrial carcinoma usually detected signal intensity similar to the normal myometrium on T2, تبقى low on T2, وenhancing less than the myometrium in the post-contrast study. It enhances less than the normal myometrium on the post-contrast. Here in the post-contrast, the enhancement of this intracavitary lesion is low than the normal myometrium. Myometrial invasion and presence of necrosis proved to be high predictive for the diagnosis of malignancy. What about diffusion weighted sequence? A variety of endometrial lesions, Fuji et al. Have studied the endometrial lesions on diffusion weighted image, and he found that malignancies as endometrial carcinoma and carcinosarcoma have lower EDC values than the benign lesions, including the submucosal leiomyomas and the endometrial polyps. However, there is always overlap between benign and malignant lesions because sometimes cellular leiomyoma may cause restriction. Necrotic or hemorrhagic tumors may cause restriction even if it is not malignant, and low-grade endometrial carcinoma may not be restricted on the other way. This is polyp and pedunculated fibroids. Again, how to differentiate. This is a myoma. When you find multiple myomas, I am more with fibroid, and this lesion, it's not so low as the other myoma, but usually the pedunculated fibroids are usually edematous and may cause, there's some edema in them and may undergo degeneration also. So this is a pedunculated fibroid. And there is a polyp here. And this article shows the differentiation. The patient has both. She has a pedunculated fibroid and a polyp. This polyp is, you know, here it's more hyper intense on T2 than the myoma. So this is a polyp and this is a myoma. And this is our case. It is on the group also. If you can see, this is a intracavitary mass, Broccoli sign. I will see you with the Broccoli sign after that. This is the pedunculated prolapsed mass, but this mass is relatively hyper intense than the myometrium, and it shows cystic changes. So this is with polyp. This is cystic changes present in it. So this is with polyp. So prolapsed endometrial polyp. This case was diagnostic dilemma at a time. She was a female 28 years old and presenting with abdominal pain and coming with this picture. The uterus is distended with a fluid-like structure with echogenic structure. It appears to me at first as being a fetus inside. I thought the patient was pregnant. She said that she's not pregnant. There is an ovarian cyst, but just simple ovarian cyst or even a follicle. And she said that she has menses only from 2 weeks and pregnancy test negative. There is a myoma anterior wall here. We couldn't say what is this. We said that there is an intracavitary complex cystic lesion. We could not say that it is retained products of conception or whatever because there is no history of pregnancy. And then the patient solved the problem here. This is the only cystic and with echogenic-like structure here, hyper intense structure here, and the cervix is normal. And then the patient served the problem by spontaneous expulsion of a degenerated fibroid. This is marked degeneration of submucous fibroid causing her abdominal pain, and so sometimes the degenerated fibroids give a very strange appearance. So when you find that, you must put it in your differential diagnosis. After excluding, especially in this age group, after excluding the pregnancy-related conditions. And this is the intracavitary prolapsing masses. When you find mass distending the cervix, it's not necessarily coming from the cervix. It may be prolapsed from the uterus. And this is a case was posted on our group by Dr. Pankaj. And this is a Broccoli sign. This is the typical Broccoli sign described in the prolapsed intracavitary uterine masses. And there is a more rare lesion. So the main differential diagnosis will be the polyp and the fibroid, and then excluding malignancy mainly in the postmenopausal age group. What is about this lesion? This is polypoid adenomyoma. What is polypoid adenomyoma? It is a rare uterine endometrial polypoid tumors of mixed epithelial and mesenchymal origin. They are mixed epithelial and mesenchymal origin. Their features on imaging confused with prolapsed leiomyomas or malignancy. Hemorrhagic cystic spaces in prolapsed uterine tumor. Here is the prolapsed uterine tumor showing cystic spaces. It takes less enhancement than the myometrium. And here there is the T1 showing that these cystic spaces contain blood. They contain blood. So this is this characteristic for the polypoid adenomyoma, but take care that sometimes fibroid, if there is red degeneration in a fibroid or malignancy, may cause also blood in pedunculated lesion. So we have to see all the multi-parametric MRI in this lesion, if there is enhancement or not, in order to diagnose polypoid adenomyoma from the more common leiomyoma or malignancy in the postmenopausal age group. This is also another paper about the polypoid adenomyoma versus endometrial polyp. The author said that the polypoid adenomyoma sometimes show predominance of cystic components, whereas the endometrial polyps the majority of them are solid, only with minimal cystic changes. So this is a polypoid adenomyoma, and this is a polyp. The frequency of cysts, hemorrhage, and myometrial invasion are significantly higher in polypoid adenomyoma than in endometrial polypoidal lesion. Endometrial polypoidal lesion encompass various conditions from physiologic changes to benign physiologic changes, as we say in the childbearing age, the pregnancy-related conditions, to benign or malignant lesions. Differentiating between various causes of endometrial polypoidal lesions sometimes is difficult by transvaginal. But as we see in the first slides, that sometimes transvaginal ultrasound can be conclusive, especially if we add 3D and Doppler. Multiparametric MRI, including T2 weighted images and T1 fat saturation, contrast enhanced and diffusion weighted images can be helpful in differentiating different types of endometrial polypoidal lesions to reach the specific diagnosis. And here this is a nice table from this paper also. It's Lee et al. 2020, characteristic multi-parametric MRI findings of endometrial polypoidal lesions. Then when you look on the T2, when you find low signal intensity on T2, then we are talking about leiomyoma, but sometimes the polypoid adenomyoma may be low in T2. Variable signal like the degenerated leiomyoma and the lipoleiomyoma. Of intermediate signal intensity is the endometrial carcinoma, carcinosarcoma, adenosarcoma, endometrial stromal tumors. All this can give intermediate signal. Regarding the endometrial polyp and the endometrial hyperplasia, they can give high signal intensity. As we said before, they are more high and with cystic changes in most cases. Regarding contrast enhancement, on the contrary, the endometrial carcinoma is the least in the contrast enhancement. It takes less enhancement than the normal myometrium and delayed enhancement. Of variable contrast enhancement is the leiomyoma and lipoleiomyoma, and according to the presence of degeneration or not, and according to the cellularity also. If we have mild enhancement, we are talking about endometrial polyp and endometrial hyperplasia and polypoid adenomyoma. But if we are taking about marked enhancement, then we are on the malignant side, but not the endometrial carcinoma, the carcinosarcoma and the adenosarcoma, well, endometrial stromal tumor. Diffusion, what about diffusion restriction? If they are not restricted, we are more with endometrial polyp, endometrial hyperplasia, and polypoid adenomyoma, except if there is hemorrhage, there may be restriction. If we have blood spaces, it may cause restriction. If it is variable on diffusion restriction, we have the leiomyoma. Sometimes the leiomyoma, so we cannot by diffusion differentiate between leiomyoma and leiomyosarcoma, because sometimes the cellular leiomyoma cause restriction. But can we depend? We can depend on the ADC value. The ADC value will be more lower with the malignant lesions. Mild diffusion restriction with the adenosarcoma and marked restriction with the endometrial carcinoma and carcinosarcoma with stromal tumors. This algorithm also diagnostic algorithm for the endometrial polypoidal lesions. First we look on T2. If we have low signal intensity, then we are talking mainly about leiomyoma, either lipoleiomyoma if we found fat, or no fat, then it is leiomyoma. The lipoleiomyoma is more rare. And high signal foci due to hemorrhage will be polypoid adenomyoma. If intermediate to high signal, then we can look on diffusion. If there is no diffusion restriction, we towards benignity, endometrial polyp or endometrial hyperplasia. If there is contrast enhancement, less contrast enhancement with the endometrial carcinoma, variable with the cellular leiomyoma and degenerated myoma, and marked contrast enhancement with the carcinosarcoma, mainly carcinosarcoma, adenosarcoma, and endometrial stromal sarcoma. I think by that we have generally have an idea how to manage and how to approach intracavitary uterine lesions. Sometimes it's not, it's good, and sometimes we need more to confirm that it's a rare entity. Thank you.